Today we'll talk about thoracic trauma. So we don't know when exactly the trauma can occur and chest trauma, so one has to be vigilant around for this surrounding, and prevention is better than cure. Otherwise, it's a potentially life-threatening condition, so one has to save himself from the surroundings and potential threats, as any minor penetrating injury to thoracic cage can lead to fatal injuries. So there are a lot of mortalities, especially in the developed countries, and people are spending a lot of money and budget on prevention of thoracic trauma and management of thoracic trauma. And 25% of trauma deaths have chest injury as contributing factor. So the causes of thoracic trauma include blunt trauma, penetrating. We'll discuss the signs and symptoms and management of the thoracic trauma. So falls 3 times from the height of the patient, blast injuries, overpressure, and plasma force into alveoli all cause thoracic trauma. And the plasma pressure can give rise to a ARDS condition. Blunt trauma by any moving object or patient having decelerating injuries in a car accident all give rise to blunt trauma. Penetrating trauma is potentially life-threatening, as we don't know how deep the penetrating object might go, and there are heart, great vessels, pulmonary vessels, all surrounding the chest, and there's a potential for life-threatening injuries in that case. Airway injuries are a potential life-threatening cause, and they develop when the penetrating injury into the chest allows the pleural space to be exposed at atmospheric pressure, and there is sucking chest wound. So what are the causes of sucking chest wound? And it includes the stab wounds and impaled objects, knife, missile injuries, all those things. Severity is directly proportional to the size of the wound, and atmospheric pressure forces air through the wound upon inspiration. Shortness of breath is very common sign of pneumothorax. Patient can develop a central chest pain, or patient can develop difficulty in breathing while a tall man is cycling and a fall. So it gives a picture of rib fractures and history of rib fractures along with shortness of breath signifies that there might be underlying pneumothorax. Pain is a second common complaint. Sucking or gurgling sounds as the air moves and out and the pleural space through the wound, and there might be a surgical emphysema along uh, with pain and difficulty in breathing, and which signifies the injury to lung or injury to the tracheal structure or bronchi. Management of a sucking wound: apply the chest seal and occlusive dressing with a release valve or a 3-sided dressing, and observe for development of tension pneumothorax. That's very important in order to save the life of the patient. So tension pneumothorax is air within thoracic cavity that cannot exist the pleural space, and it compresses the lung and thereby decreasing the ventilation and also decreases the perfusion. So it has a dual effect. It can compress the mediastinum and affect on the contralateral side as well. Fatal if not immediately identified and treated, and reassessed for effective management. So the patient could be anxious, there is increased respiratory distress and unilateral chest movement and unilateral decrease or absent breath sound. Now the tricky thing is the patient has asthma or he's a routine attender of A&E with asthma. Then he will forget a trivial injury that could lead to pneumothorax, but he will just give the history of exacerbation of asthma. So one has to examine the patient and take history thoroughly in order to rule out what is the exact cause, and asking the patient that is it the same as before is a good question, and that gives a clue that no, it is slightly more as compared to the previous episode. And why do you think is more? Then patient might tell that I got injury from by this mechanism. So in the patient with respiratory disease, with emphysematous lung conditions who have low saturations, this condition is very, very difficult to pick. And the patient who have underlying emphysematous lung disease, they are more prone to develop pneumothorax and tension pneumothorax. Late symptoms of tension pneumothorax: jugular venous distension and tracheal deviation and narrow pulse pressure. So they present with a sign of respiratory distress, but if patient is heart failure, he's huffing and puffing all the time, then again it's difficult um, to rule out, because the JVD is always there and it will be missed. So underlying saving the life is very important, and patient presenting with chest pain who had history of angina or who has history of respiratory difficulties, then it's very difficult, and the patient are treated as ACS, and later on when the symptoms doesn't improve, then the later workup with the CT scan, or most of the time the patient, if the respiration doesn't improve, clinician thinks that it might be PE, and the workup of PE shows tension pneumothorax, which could easily be picked with history and clinical examination. So one has to examine the patient, spend the time, listen, auscultate, percuss the chest. These are all basic signs which are very, very, very important in order to save the life of the patient. Otherwise, patient may die with tension pneumothorax, and postmortem will signify that this is a tension pneumothorax, and the diagnosis was MI. So Jvd and Tracheal Shift, there's a decreased input and output from the heart with compression of the great vessels. Increased pressure moves towards mediastinum and compresses the lung to the uninjured side. So management of tension pneumothorax, chest seals, needle decompression, high flow oxygen, and back valve mask ventilation. And if the patient has very low saturations or low PO2, then we can intubate the patient. Chest tube is very important way of keeping the trapped air sucked out of the chest cavity. So needle thoracocentesis, it's a quick and easy procedure. Second or third intercostal space, mid-clavicular line. One has to be very, very thorough in delineating the surface anatomy, because if there is surgical emphysema, then things would be distorted, and slight deviation of the needle could hit the internal thoracic artery, or if you go deep, it can hit the lung or any vessel. So it has to be a controlled move. and this is the way you have to slide the needle over the top ridge, avoiding the neurovascular bundle underneath the rest. So, in summary, we have reviewed a few anatomical and physiological aspects of the chest and discussed the trauma of the chest, signs and symptoms, and the emergent management of open pneumothorax and tension pneumothorax. One thing is the vascular injury. It is very difficult to treat for an inexperienced person, and but in the experienced hand, vascular slings could be applied, and there could be slings could be tied with snuggers in order to control the bleeding, and vascular surgeons could be called to control the vascular injuries. If you have any questions, you can write in the comment box, and I would be happy to answer them in the comment or make another video for that.